so let's go on and talk a little bit about the SGLT2s, because you brought it up. So we're going to come back to all of this. The newest agents to enter the type 2 diabetes market are the SGLT2 inhibitors that leverage aspects of renal glucose handling to lower glycemia. And to me, as someone who went to medical school when pterodactyls roamed the earth, I mean, this is one of these moments of, nobody thought of that, you know? Or maybe they didn't have the tools to do it.
Well, no, right. They did think about it. The whole science about it started 40 years ago.
Okay.
And they knew, because we know that the kidney reabsorbs back glucose. So if you stop it, you really reduce a lot of exposure of glucose.
Now, we've got some numbers here, actually. 90% or more of glucose reabsorption via the kidney is mediated by SGLT2 and GLUT2 in the S1 and S2 segments of the proximal tubules. And if any of those letters or numbers are unfamiliar, there's always Harrison's. Now, SGLT2 receptors are overexpressed in patients with type 2 diabetes mellitus, increasing the kidney's capacity to reabsorb glucose such that glycosuria does not occur at glucose levels that normally would provoke it in non-diabetic individuals, with the result that too much glucose is reabsorbed, contributing to hyperglycemia. It's one of these really nice balancing acts. There's more glucose coming back, glucose in your blood goes up. So these agents inhibit activation of SGLT2, lowering the threshold for urinary excretion of glucose and allowing elimination of excess glucose. Now currently, and here go some names, get ready. Currently, there are 2 FDA-approved agents. I'm going to try this one again. Canagliflozin, starting dose by way 100 milligrams, and dapagliflozin, starting dose 5 milligrams. These agents both lower glucose in an insulin-dependent manner, meaning independent manner. Did I say dependent? Let me try that again. Insulin, well, it shouldn't be insulin-dependent at all. It's in the, fine. Insulin-independent manner. Thank you. Meaning that their efficacy is not affected by insulin resistance or the level of beta cell function. What an ideal situation that would be. Now, canagliflozin and dapagliflozin are once-daily oral agents approved for use as monotherapy or as adjuncts to other therapies, including insulin and incretin therapies. They reduce A1C by about 0.5 percentage point to 1 percentage point as monotherapy and provide additional A1C reductions when added to metformin, about 0.7 percentage points, glimepiride, 0.63 percentage points, basal insulin, about 0.6 percentage points, up to 1, or as the third agent. Now, beneficial reductions in FPG and PPG are also seen. They are not associated with hypoglycemia, by the way, although they may increase hypoglycemia in combination with sulfonylureas or insulin, slight increases in urinary tract and genital tract infections, which generally are easily managed, are the most common side effects seen with the SGLT2s. So, for what patients would you consider using an SGLT2 inhibitor versus a DPP4 inhibitor or some other option? You want to start us off on this, Cal?
Sure. So I think most patients are going to be on metformin as initial therapy, and then the patients that potentially could benefit from this class of medicine are patients who are obese or are hypertensive. They do have some blood pressure lowering effects. But you want to pick patients that have near normal or normal renal function, just because the mechanism of action as kidney function declines, it becomes less effective, exactly. And they do, when I read the literature, they do seem to be a little bit more potent than DPP4s in general. So weight loss, a patient that's obese, maybe taking blood pressure pills, needs, a 1.5% A1C reduction. I think that's a nice patient for this class.
I come back to that. It's a percentage point, right? Because if you have an A1C of 10, a 1% reduction is 0.1.
Right.
So you mean percentage point reduction. You want to go from 8 to 7, 7 to 6, something like that.
Right, and as Yehuda mentioned earlier, that the higher, when you look at these trials, the higher you had your baseline A1C in that trial beginning, obviously you get a better benefit when you look at those trial results.
Now, Maria, there are some aspects of these agents that make them attractive for the overweight patient, right? And obese type 2 diabetes mellitus patients are really a challenge. So what aspects of these agents work in that situation?
Well, any degree of weight loss is good for these patients, especially since they're obese. The question becomes also, is it clinically meaningful? And for some, 2.5 pounds or 2.5 kilos, roughly 5 pounds, is not going to be meaningful enough because they still have quite a long way to go. So what would be clinically meaningful is when you start to see the impact on comorbidities relevant to the weight loss and to be able to reach blood pressure goals. Now, granted, you may still have other medications, as was pointed out earlier. But if you're getting to goals and multiple goals, in addition to A1C, that's quite important in terms of cardiovascular risk reduction as well.
But I think you alluded to this earlier. One of the tricks in getting patient buy-in is to show them progress. So, all right, 2.5, 3.5 kilograms, maybe it's not going to be clinically significant in terms of physiology in a 200-kilogram patient. But if they see progress, gee, something's working, maybe that gets you some buy-in.
Oh, we're using kilograms. 200 kilograms is 440 pounds. Yeah, so we need to be careful about that. And 2-3 kilos is
we'll
6-7 pounds.
Kilos.
This is 6-7 pounds. And that's important because if you grab another 5 pounds from a GLP-1 inhibitor, now you're at 10-11 pounds, and you add a metformin so you don't gain. So you get a control, and not only did you not gain weight, but you lost about 5 to 8% of weight loss with this combination. That becomes meaningful. And so if it would be only 2.5, I agree with you. If it would be only 3%, maybe not enough. But what we are seeing is that we will get added benefit. More importantly, the patient who starts on a combination like that, and I say, hey, you do lifestyle and this, after 3 months, I say, look at what lifestyle is doing for you. And so that promotes the continuation of lifestyle with the promise that by 1 year, they're, okay, we'll bring back some of the medication off. I think the SGLT2s are a very important armamentarium that we have. They are more potent than we think they are. They are working there only in people with good creatinine clearance.
This brings up a topic we discussed just before we went on about someone who was told that she could lose 1 pound a week on a diet. She said, well, that's not very much. Then she said, how'd you like to lose 52 pounds a year? She said, oh, that would be great. You've got to get the right perspective here, right? And what about some concerns you have? I mean, dapagliflozin is contraindicated in what? Moderate renal impairment? What's up with that?
Well, this has to do primarily with effectiveness. So because the SGLT2, it's a transporter in the kidney, and there's kidney failures, less of them are working, and so there's less capacity to absorb or reabsorb glucose. So they're not effective very much below 60. There's also some concern about how they're being cleared. The other one on the market right now that we have, the Invokana, the canagliflozin, this one actually, we're looking at creatinine clearance of 45, not about 60. So it's still available for most.
Kalia, there's something out there about active bladder cancer and the use of these drugs? Yeah,
there was, obviously, if you have somebody with active bladder cancer, you don't want to be increasing glucose to the bladder itself. The one way that these do work is, obviously, they inhibit the transporter so that you're peeing out more sugars, and that's what really leads to weight loss, is you're losing calories every day. So people do have an increased risk of mycotic and UTIs, mycotic infections and UTIs.
What's surprising to me in this new age that we're living in, I was taught the best thing you can do for a diabetic is to have him stop spilling sugar. And here these drugs are encouraging that.
This is a true paradigm shift, but it used to be that was the only way we could measure, how bad they are. It was glucose in the urine.
Right.
Now we don't. We're looking at the finger, and that's where we measure that. So if what we do today, we don't allow the glucose to come back to the serum, it does not come back to circulation, in my mind, and again, hopefully they're going to prove that out, we also reduce the exposure of the glomeruli, this is the filter itself, to glucose, because you don't allow this glucose to go back.
Oh, so it's not
so I think,
recirculating.
correct. And so I think that long term, we'll find out that there may be a reduction in diabetes nephropathy because of that, because part of glucose is toxic to the glomeruli. And that's why we're seeing so much diabetes nephropathy. So I do believe, that's me, and again, I'd like to see science back me up on that, that there will be a reduction of that. So it's a very good mechanism.
That means that my old standby, the old urine dipstick, that's gone.
It's gone.
Because you can't tell about diabetes management if what you're trying to do is encourage spill.
You also did not know, Peter, that it used to be that 180 was your level of when to sweet. So somebody had sugar in the urine, you said, oh, so you must be 190 or 200.
Yeah.
Not anymore. Now we know that actually up to 14 people with diabetes will not actually spill in the urine.
You are destroying my last bastion of hope. Everything I learned is wrong.
On this part.
That's okay. It helps to read the literature now, doesn't it? But I mean, this is all a sea change, isn't it, in the way we're dealing with diabetes?
It is. And just going back, you know, I learned that you should never use beta blockers in heart failure. And, you know, of course, we've done a 180 on that.
Not to mention using beta blockers with bronchoconstrictive disease. We do that too sometimes.
That's right.
It all depends.